blocker overdose. So your handout says about 10,000 a year. And you see about 1,000 in kids a year. Who do you think is going to be at most risk? Who's going to walk into your ER with a beta blocker overdose?
Toddlers.
Kids. Think kids. Grandparents' house. Access to medicine. So think kids. What else?
Geriatric patients who forgot they took them.
Geriatric patients who forgot they took them. Okay, so think poor vision, think forgetfulness, I don't want to say senility, but don't have a system set up. Think also people coming out of the hospital who had a beta blocker at home, put on a different beta blocker in the hospital. Nobody told them that one doesn't cancel out the other. Multiple beta blockers. Okay, so those are going to be common. So unintentional is probably the most common. I've listed there also for you some intentional. So the intentional overdoses with beta blockers are often related to depression, comorbid depression, usually women, young women, and they're on it for non-cardiac reasons, or they took someone else's. So what would be non-cardiac reasons to have beta blockers in your possession?
Tremors.
Tremors? Anxiety? Okay, less likely.
Migraine.
What other?
Migraine.
Two other, migraines? Pardon? It's a gland story about there. Hyperthyroid. Remember, we use beta blockers for hyperthyroid? Okay, so those are your profiles of people who are likely to have beta blocker toxicity. Okay, where are the beta 1s? Beta 1 receptors.
The heart.
Heart. Oh, let's use red. Okay, where are the beta 2s?
Migraine.
Lungs. Let's use blue because they're in trouble. Any other place? Another red. Pardon?
Arteries.
Arteries, vasculature. Okay. Okay, so when we use a drug that's going to block those effects, then what kind of side effects are we going to expect to see?
Decreased heart rate.
Okay, so decreased heart rate. Possible decrease in respiration, bronchospasms. Those are less common, honestly, but they can occur. What are we going to see in the vasculature? Decreased blood pressure. Remember, blood pressure determinants are
Heart rate.
cardiac output times peripheral resistance. What are the determinants of cardiac output?
Ejection fraction.
Heart rate, stroke volume, ejection fraction. Okay. So if we hit this and we hit this, because we're blocking beta 2 receptors from what? What are we blocking them from? What can't act if you block that beta 2 receptor?
Adrenaline.
No acetylcholine, epinephrine, norepinephrine. So mostly the catecholamines, right? Okay. All right. Good. So decrease in heart rate, respirations, decrease in blood pressure. Those are normal pharmacologic effects. In this drug, they will be exaggerated. Okay? So you can see almost any kind of bradyarrhythmia. You can see profound hypotension, including shock. Okay. There's some other toxicities that we don't really think about. They're part of the way the drug acts. We don't really worry about them so much. But they're listed there in the middle. There's 3 of them that affect the toxicity. Membrane stabilization, lipophilic, and intrinsic sympathetic activity. So membrane stabilizing activity, where do we use beta blockers in terms of arrhythmias? They're class 4s, class 5s. So AFib, someone said AFib. Okay, so AFib takes advantage of what? Action of the beta blocker. What's the problem in AFib?
Irregular heartbeat.
Okay, why is it irregular?
The atrium is.
Okay, so the atrium is fibrillating because the SA, no, you got ectopic rate producers. So what can we affect that? Can we change that? No, so where do we target? For rate control, what are we taking advantage of the beta blocker will do?
Lower heart rate.
Lowers heart rate, but it does sit through the SA node, but there's ectopic foci that are causing that rate to go up. So how do we stop that rate? What's the problem? Why does it matter if we have a high heart rate?
The ventricles aren't having time to fill.
We don't get enough time for ventricles to fill, so what do the people feel like? Oh, I can't move, I'm gonna pass out, my heart is beating so fast. Okay, so to get adequate ventricular filling,
Slow down.
we do what?
Slow down.
Okay, so here's the SA node, but we got all these independent players. So what do we target? We target that, right? The dromotropic effects of beta blockers are to decrease AV conduction, right? Okay. So we can stabilize those membranes and keep them from depolarizing, and so we'll slow down conduction. Okay. So in some of these, when we have overdose or more than we want, we get into trouble with those membrane stabilizing effects. Propranolol, acebutolol. Keep acebutolol in mind because it is the most toxic of the beta blockers. Keep propranolol in mind because it's the most common beta blockers in overdose situations. Lipophilic. The one to keep in mind here is that some beta blockers are lipophilic, some are not. They are water soluble, like Nadolol is water soluble, Tenormin. Propranolol is the queen in this area. It can move into the brain easily, okay? Because of that, you can get neurologic symptoms with a beta blocker overdose that's due to propranolol. So keep that in mind because it's kind of unique to that characteristic of beta blockers, and propranolol tends to be the most common one of that. The other is intrinsic sympathetic activity. This tends to be the newer of the beta blockers, ones we probably don't talk about as much. Acebutolol falls in there, Pendolol is one in that group as well. These drugs have some agonist activity in that they will stimulate sympathetic drive. So sometimes we want that. We want to beta block them, but we don't want them to go into heart failure, so we have these agonists that can increase sympathetic drive, keep cardiac output up, they don't go into failure as much. So if you have an overdose from those drugs, then sometimes some of these things don't show up as much. Not as bradycardic, they don't have as many as arrhythmias. So if you've got a more mild overdose, you may not see those things if it is a beta blocker with intrinsic sympathetic activity. In big overdoses, it doesn't matter. It washes out. So those are the three things that tend to influence toxicity in that class of drugs. Questions about those? So the one thing that is so important when you got an overdose is you try your hardest to identify what did they take. So if somebody can bring in a bottle, great. If they bring in a bottle and you're not sure, let's say it's all gone, and the person who's brought them in says, I don't know how many they had in there. Call the pharmacy. There will be a number on there. Call them. Okay? Pharmacies would help you. Okay? If it's like a big Walgreens, then they have access to everything everybody's filled. If it's the VA, they have access to everything people have filled in that system. So it doesn't have to be just that store they can access. Am I right? Those of you who've worked it, okay. Kinetics, Most beta blockers have short half-lives, 4 to 8 hours, but in an overdose situation, often, and this will go across all the drugs we're talking about, usually half-lives get prolonged. Just because you can't absorb, the drug absorption characteristics are modified, because often with amount or what else they've taken. When you see a cardiac overdose, think other cardioactive drugs, okay? They may have taken more. If it was an intentional, they may have taken everything they had. If it's kids, they may have gotten into more than just one drug. So think multiples. Let's see. A lot of these cardiac drugs are sustained release. So their onset of symptoms may be delayed. Their toxicity potential is quite drawn out. Clinical features of beta blocker overdose. So risk factors, co-ingestion with other cardioactive agents. Underlying heart disease. So if you've got a heart failure patient that takes an overdose of beta blocker, that is bad. Okay. Ingestion of sotalol. What do you remember about sotalol? It's unique in this category of beta blockers. Where have you seen that before? Remember the disease we're most likely to use it. We will use it, we'll admit people to the hospital, and we'll try to convert their AFib with sotalol. Okay. So sotalol is a class 3A antiarrhythmic. What do you remember about those? Or what do you remember about the bad thing about antiarrhythmics? When we use them, what can happen?
They interact with a lot of things.
Okay, Ani is making the picture of them, the torsades, and somebody may have seen it, okay? So when we use antiarrhythmics, one of the bad things was that we can bring on more malignant or toxic arrhythmias, sorry. So sotalol, if you have an overdose of sotalol, you have to admit them because they need cardiac monitoring. They are at high risk for QTc prolongation, and they are at high risk for torsades. Okay. So sotalol is different. And it has a very long half-life compared to the other beta blockers, so it causes a lot of trouble. So ingestion of sotalol, and I probably left out ingestion of sotalol or a beta blocker with membrane stabilizing activity. So those are the three big ones. Sotalol, bad news. Propranolol, most common. Acebutolol, most toxic. Okay? Those three keep in mind. Okay, next page. Cardiovascular effects. So bradycardia. Okay, you got that one down. You know why it causes a decrease in blood pressure. Ventricular arrhythmias we're attributing to its membrane stabilizing activity because it slows down those fast channels, allows for other bad arrhythmias to come in. So they're usually ventricular. Other potential are mental status changes. Those tend to be more common with propranolol. But if you have a co-ingestion of a different product, that may also be in play. Respiratory depression we talked about, bronchospasm, not as common as you would think, but can certainly happen because at those higher doses you tend to lose beta-2 and beta-1 specificity. Hypoglycemia, why do they get hypoglycemic? This is an important one, it often gets overlooked.
Oh, it masks the symptoms of hypoglycemia?
It does, but that's masking symptoms of hypoglycemia because so you can't recognize them. They actually get hypoglycemic. Not perfusion. Okay, so go back to the things you know about hypoglycemia. Why does it usually occur?
Take too much insulin?
Too much insulin?
Not enough food.
Not enough what?
Carbs.
Not enough food. Okay. What else?
Exercise?
Exercise, okay. What feeds the body if you aren't giving it food?
Liver.
The liver, okay? So there are beta receptors on liver that when stimulated, because if you get low, what your adrenal glands do?
Release.
Dumps out epinephrine, goes right to the liver, stimulates those beta receptors, and glycogen's broken down quickly and put into the bloodstream. Okay. What is the hormone that right now, what hormone is keeping your liver producing glucose for you all the time? Glucagon, okay? Glucagon comes from what cells in the pancreas? Say it again. Alpha, good. So alpha cells have beta receptors on it, okay? So one of the ways we also can get your blood sugar up is if we stimulate your alpha cells to produce glucagon. Glucagon goes to the liver and does what? Helps you break down glycogen and release. So we've got kind of that all the time release of sugar. And then we've got an emergency where we get epinephrine up and out, and maybe it can make the liver do something right away. Glucagon's a little bit slower, okay? So because you knock out those two pathways, then blood sugar levels will drop. So anytime you suspect a beta blocker overdose, check a blood sugar. And I've got it on the list of things to do. See all this stuff you know and how it all comes together? It's beautiful. Okay, toxicity of specific agents we've talked about. Acebutolol, most toxic. Propranolol, acebutolol, metaxalol. Those last two are not used very often. Metaxalol is eye drops, so patients can get overdosed through eye drops. They have membrane stabilizing activity. So probably what I would remember there is that these drugs, while we use them to do these things, often also have effects on the ability of an action potential to go through a cell. And because of that, we get arrhythmias. And most of the time they're ventricular arrhythmias. So we always need to be thinking about that. Sotalol, worst. These others, what I would take away is the one that I always need to think arrhythmias in a beta blocker overdose. Sotalol we've talked about. Okay, let's go through lab evaluation. So one of the first things you want to do is slap an EKG on them, right? Okay. So what would we expect to see? If we are slowing down the conduction through the AV node, where's that going to show up on the EKG?
The bradycardia.
Okay, bradycardia, but where in the PQRS? Too many. Okay, yes, this prolongs, okay? Even when you're on a beta blocker therapeutically, the PR interval goes out. So this PR interval is going to go up. Okay. What's going to happen to the QRS? It's going to go up. And QTC may go up depending on the agent. So looking down there, any Brady yes?
When you say it goes up, do you mean that it's wider?
Longer, yes,
Okay.
wider, thank you, yes, wider. Prolonged, more time through. Any Brady dysrhythmia can occur up to asystole. So what would be Brady dysrhythmias? Name some of them.
AV blocks.
AV blocks, so first degree, beta blocker, therapeutic, first degree AV block, common. Okay, so you could have a second, third, asystole, what else? So bradycardia could be in that category. Any others? Some of the others you may not have had. Sinus pause.
Yeah.
You just don't have all is that what you were
Yeah.
I
saying?
was trying to, I was like, what was that one?
Junctional rhythms where the atrium is not functioning and you've got the AV will take over if you don't have any sinus activity. Okay, good, very good. So the other thing, get a finger stick blood sugar. Also looking at calcium, their renal function, particularly if they're an older patient. We want a baseline calcium because we may use that in treatment, so we would want that so we don't give them too much. Let's see. So management, you can use activated charcoal for a beta blocker overdose. Hypotension, you're going to use fluids, so isotonic fluids, and that would be what? What's an isotonic fluid? Say what? Normal saline, yes, half normal saline. Symptomatic bradycardia, use atropine. So what's atropine do? How does it increase your heart rate? Doesn't bind to epinephrine, but your sinus node is it's innervated, so it is mostly, the predominant effect on the SA node is what?
The vagus?
Not the vagus, the sympathetic. Well, sorry, you have both. So you've got parasympathetic and sympathetic. What you're doing is you're knocking out that parasympathetic, right? Allowing the sympathetic to drive heart rate. Okay, you do not have to know the dose that's there. For arrhythmias, using sodium bicarb or magnesium. Remember, one of the things we talked about back under antiarrhythmics was that a risk factor for the development of a fatal arrhythmia or a malignant arrhythmia was low magnesium, remember? And we talked about it being one that most people don't necessarily look at. So here it comes again. So to treat or to decrease the risk is using magnesium. Hypoglycemia, we're going to treat with IV dextrose, so depending on the severity. Multiple doses may be necessary. If they have seizures, propranolol overdose, then you'd use a short-acting benzodiazepine like lorazepam. It comes as an IV product. Okay, so those are your common ones to start with. So if that doesn't work, what are your next options? Well, one that you may not have thought of is glucagon. It's an unusual effect of glucagon. It's very brief. Your body will quickly adapt to it, but it releases intracellular calcium pools, and so it can augment contractility. So you can start with that. And use it either as a bolus or as an infusion. The result should be pulse goes up, blood pressure goes up. So that's what you'd be looking for. Main goal is to keep mean arterial pressure at 60. If that doesn't work, you can use IV calcium gluconate or calcium chloride. Calcium chloride. So, but you've got to monitor the calcium concentrations. This may be in people at more severe, or if they haven't ingested an extended release product, because your glucagon may not give you the effect for long enough for them to recover. If they're very hypotensive, you can use a oppressor, so you can use epinephrine. So you're using a catecholamine to overcome the effect of that beta blocker on that receptor. So it's a partial, so it's not remember we talked about antagonists that sit there and don't get off a receptor, and then we talked about competitive antagonists. So here, epinephrine will vie for that receptor. So what we're doing is we're just flooding the market so that we can get on as many receptors as we can as that beta blocker dissociates and then sits back down again. Okay? So that's why that works. You can also use high-dose insulin and glucose infusions. So we're going to see this also with the calcium channel blocker. It may not be something you think about. But the reason why that this works is that it is thought that over time, through this overdose situation, the cardiac muscle runs out of energy. And so using the glucose and the insulin to drive energy into the myocyte helps it recover, helps you increase contractility and pulse. Okay. So in terms of high dose, we're using in the range of 1 to 2 units per kilo per hour. That's very high. So you're going to have to use glucose to keep up with it. Now, one of the problems that comes about when you do that is that always think potassium, because insulin will drive potassium into the cell. So if you measure it, it's going to look like they're low. But the potassium has moved intracellularly. Listen when Dr. Perry talks about DKA, because that's one of the problems we run into when somebody comes in DKA, is that we give them this big insulin infusion and they come in with normal potassiums and they drop because they've lost a lot of potassium before you ever get to them. It's the same thing. So here you have to look at their potassium. If you're watching potassium because it's getting low, you also have to think about magnesium. Okay? So electrolytes become really important when you're dealing with someone who's got a beta blocker overdose because of the drugs that you're going to give them. Okay. So think of that first as being the top of that page being what you're initially going to do. Some people will, in a very big overdose, they will start that insulin and glucose infusion early because it's delayed in its effect. So some will get that started while they're doing other things. And then the glucagon, the calcium, and the vasopressor are usually going to come if patients aren't responding. Okay. When it says that insulin has a strong dose response, we talked about this a long time ago. Here's what they're talking about. You got drug or dose, and you got effect. So for every incremental dose you increase insulin, you get an effect. Whereas a lot of drugs will have this kind of dose response curve. You get good effect here, but it plateaus off. You don't see a plateau here, which is good. Not very many drugs we have do that. Furosemide's another one of those. They're high ceiling drugs. They don't hit that plateau very easily. The last thing is lipid emulsion therapy. This is being used sometimes in when you have a lipophilic drug that's been ingested. So most of the calcium channel blockers are lipophilic, propranolol is lipophilic, some of the other beta blockers are lipophilic. So they use fat emulsion to draw the drug into the vasculature and trap it. It doesn't have a lot of data behind it, but it is part of the protocol. It's recommended that if you got to that situation that you would be calling. And if you'll look at each of those up-to-date forms that I've given you, at the top they give you a 1-800 number, and they also tell you call a medical toxicologist and have them walk you through what to do. In terms of disposition, sotalol overdoses are going to take you the longest half-life, most worrisome in terms of arrhythmias. So those folks are always going to be admitted. They're probably going to be held longer. People who've had a moderate ingestion probably can be managed through the emergency room. Those that have developed hemodynamic instability, those you would admit. Okay? Got it? All right. Let's look at calcium channel blocker overdose. The good thing here is that these are very similar in terms of treatment. Calcium channel toxicity is very much underappreciated, but they're very toxic drugs. If you look at the fourth or fifth bullet, 16% of all cardiovascular drug exposures are due to calcium channel blockers, but they account for 40% of the deaths. Remember, there's two different kinds. I've got them down there for you under review. You've got the dihydropyridine and you've got the non-dihydropyridine. The non-dihydropyridine are the most toxic because they are cardiac. Their effects are mostly on the cardiac muscle. Okay? The dihydropyridines like nifedipine, amlodipine, felodipine, those are peripheral. So they don't have that much cardiac. Okay? At high doses, they will cause a lot of problems. But most of what's going to happen with them are patients going to get very hypotensive and very tachycardic. Okay? So the only way they can compensate is through heart rate. Because the calcium channel blockers, the dihydropyridines, don't affect the heart rate. Okay? Their effects are all out here in the periphery. So they'll get very hypotensive. Now, the dihydropyridone, verapamil, diltiazem, those are more of the toxic drugs because they are cardiac. Verapamil probably one of the worst because it's dromotropic, it's chronotropic, it drives down heart rate, it drives down that AV node, so you can't conduct through it, and it's a negative inotrope. So people who have heart failure take an overdose of verapamil, it is bad. Diltiazem tends to be a little bit more balanced, so it's not as toxic as verapamil, but in high doses it will cause the same trouble. So here again, it's if you'll think about what it does pharmacologically, that we use it, then extend that effect on out, then you'll remember the toxicities. Okay? All right. And a lot of these are extended release. Most of the calcium channel blockers are very short half-life. So we've developed these great controlled release drugs. So a lot of your patients in this situation are going to come in on an extended release. I would almost assume that for these. Okay. So 5 to 10 times the normal dosing would be a toxic dose. Vital signs, again, hypotension, bradycardia, which you can predict. Because you can put them into heart failure, then you would think about the kinds of signs. So jugular venous distension, liver that is, liver that is full, pulmonary crackles. So all of those things with heart failure, think that. PR interval prolongation, again, you've got that AV, decreased delayed conduction, and bradydysrhythmia. So very similar to beta blocker. Here, though, blood sugars go up, so a little bit different. Treatment, very similar overall to beta blockers. Intralipid therapy has been used a little bit more with calcium channel blockers because most of them are lipid soluble. Specific therapies, again, if they're hypotensive, use isotonic fluids. Atropine can be used for the bradycardias. Calcium can be used, or IV glucagon can be used to raise up contractility, either one. On the next page, again, high-dose insulin and glucose also used. Now, some patients may not need the glucose as much in this situation. Their blood sugars may not fall, but you have to monitor it because you're using the high-dose insulin. Potassium, same problem here, so you're going to force it intracellularly, so monitor potassium. Magnesium, you have to use a vasopressor. Here it's norepinephrine instead of epinephrine, and then the lipid emulsion therapy we've already talked about. So very similar. If you will learn the flow for one, then what I do is modify it for the calcium channel blockers. Questions? Okay, we can get through iron and then we'll stop. Iron is bad. It's bad in overdose. The problem with iron is that it looks like candy. It is common in prenatal vitamins, and it's in higher doses in prenatal vitamins. So one of the big risk factors for iron overdose in kids is young children, moms pregnant on prenatal vitamin. So very common in kids. I have seen intentional overdoses with iron in adults. It's a bad one when they take a lot of it. Okay, so One of the things to remember with iron is, remember the salt form will dictate how much elemental iron. So again, it's back to how much elemental iron did they take in. Which of the iron salts that we talked about has the most elemental iron? Ferric sulfate, ferrous sulfate. Okay. So, and that's probably the most common one used because you get the most bang for your buck. So think about that one when you encounter this overdose. Okay, so toxicity is determined by milligram per kilo dose of elemental iron. Ingestions of more than 60 milligrams per kilo, so keep that one in mind, circle it, know that. The problem with iron is that it acts like a free radical, so it just wreaks destruction. And as we go through, you'll see it hits the heart, it hits the gut, it hits the liver. So there are about 5 phases of this overdose or this toxicity, and we're going to walk through those. The good thing here is that, remember how toxic how iron upsets people's stomach? If you ever take it, it always upsets people's stomachs. So usually they get symptomatic pretty quickly. So that's within the first 6 hours. So you get a direct injury to the GI mucosa. So nausea, vomiting, they may throw up blood. They may develop a metabolic acidosis. That's important to remember because it'll show up on your lab. Their vomit or their stools may look weird because of the color that is in the iron tablets can color it, or it's going to be the blood that they are vomiting that's also can color it. Vomiting is the most sensitive indicator for a serious ingestion. Death early on is from hypovolemic shock, so it's big fluid shifts and they die because of that. There is then a latent phase. If they get past that, or if they're not very symptomatic, then then the symptoms really don't show up for about 24 hours. That's one of the bad things about this overdose. So it's that third phase, that shock and metabolic acidosis, where a lot of people die if they make it to that point. Here it's cardiovascular toxicity. So shock. You can also get a coagulopathy. Why would you get a coagulopathy? Where are the coagulation factors made?
Liver.
Liver. Okay, so if you start having significant liver damage, you have to damage a lot of the liver before you start to see effects on bleeding time. So that'll be an important one that you're going to look at when you're evaluating them. Patients may also start to develop symptoms of liver toxicity, jaundice, coma. Death here is widespread cellular dysfunction, multi-organ dysfunction. Common for people to die in this phase. The fourth is a little bit further out, hepatotoxicity, hepatic necrosis. So if it isn't picked up or if it isn't adequately treated, the liver is very vulnerable. It takes up iron readily, so it will take up a lot of that iron, and it will start to cause destruction. So the liver failure is the most common cause of, or one of the second most common cause of death from iron poisoning. If they make it past that, then several weeks out, they can develop a bowel obstruction due to the scarring that can occur due to the damage that the iron caused. So these folks need long-term follow-up until you get out several months to make sure that they have recovered. So evaluating, you got to know the type of iron. So the elemental iron, their physical presentation can be tachycardia. If they've lost enough fluid, they vomited up enough blood. Their peripheral perfusion may be down, especially if they have started having fluid shifts. Mental status, hypotensive. The other are the GI symptoms that we talked about. So persistent vomiting, diarrhea, abdominal tenderness. So what are you going to look for? One is you want a serum iron concentration. Okay. The ones I want you to know, let me go through them and I'll point those out. So Less than 350 micrograms per mil, they're usually not going to have trouble. 350 to 500 are more moderate, but greater than 500, that's the one you must know, because that one is where you've got a significant toxicity. Greater than 1,000, death is common. So what do you want to look at? You're going to want to look at your electrolytes, your kidneys, glucose, their liver enzymes, their blood gases, because they can have a metabolic acidosis, common, so keep that in mind. Complete blood count, because if they've lost a lot of blood, that will show up there. Their prothrombin time, or the activated partial thromboplastin time. Type and cross-match them because of needing to replace blood. And then get a plain film of their abdomen, because these tablets will show up on an x-ray. And here they are, right there. And see how they've glommed up? They are just going to sit there and dissolve until you can get rid of them. Decontamination, here we use, iron is not absorbed by activated charcoal. It's one of those iron salts, metals. Metals don't tend to be absorbed well by activated charcoal. So they use a whole bowel irrigation to try and dislodge them. The drug of choice, the antidote of choice is IV deferoxamine. It's a chelating agent. It complexes that iron and makes it water soluble, and then you can pee it out. It's called a vin rosé color, but it's more like an orange or a brown color that will turn the urine. You need it early on. Indications are severe symptoms. They're listed there for you. If they have an anion gap, metabolic acidosis, if their iron level is greater than 500. If you see a significant number of pills on the x-ray, I wrote it down twice so you'll know it's really important.
Are those the only pills that do that?
No, there are others, but those are probably one of the most common in an overdose that you'll see. Doses listed there. You do not have to know the dose, but you need to know the antidote. It's fairly well tolerated. It can cause low blood pressure and acute respiratory distress syndrome. So the overview is listed there for you. Questions about iron? Always, if you're in family practice or OB, always talk to your moms and your parents about iron products, because they can buy them over the counter, and they're always shiny because we coat them to taste better going down. So they're green, or they look like M&Ms. They're red, they're green, they're pink, so they can be attractive to kids. Okay, questions? All right. So if we can meet at 9 on Tuesday instead of 10, I can finish up what's here and the other two, and then we'll cover topical anesthetics and life support on Tuesday.